So we start out immediately by the first speaker, Dr. Peter Kardos from Germany. He's a well-known pneumologist and has written consensus documents on cough, and you will see in his presentation, Pharmacotherapy of the Common Cold, so much opportunity, so little evidence. It's not that bad as the title suggests. There are evidence. There's a lot of evidence coming up by a very active research and development in this area. Very welcome, Peter.
Thank you very much, Professor Theona. Ladies and gentlemen, dear colleagues, I would like to thank of course, the organizers, but I thank you that you are coming to watch a presentation on such a trivial disease as common cold. And hopefully it works, yeah. And common cold is trivial, but it is a very frequent disease. And this is the most frequent cause for consultation in both pediatric surgery and primary care. I am an adult respiratory physician. I hope I can you tell some interesting details. Yes, this is my conflict of interest statement. Yes, this is a fascinating question. Does cold cause common cold? I am so fascinated because the patients are coming and every patient believes that it was cold yesterday, I catch the cold. But common cold is a viral disease. Why should, I don't know. But now we have the evidence, and Mäkinen investigated some 900 military recruits in northern Finland at the polar circle, and during a year, and some 700 respiratory infections were registered. And here you see the results. The lower the temperature, the higher the likelihood that you get a common cold, that you catch a common cold. But most importantly, not a single respiratory infection occurred if the temperature, it wasn't a temperature drop during the preceding 3 days before the onset of the respiratory infection. You would say probably polar circle, that is not representative for us. There is a second paper in the same journal from Falagas from Greece. Basically, the temperature is there 20 degrees higher than at the polar circle, but you have still the same results. So yes, cold weather causes common cold. What is the definition? This is a sudden onset disease in previously well people. It's very important. We don't speak about HIV patients. We don't speak about other patients. We don't speak about pneumonia. We don't speak about exacerbation of COPD. Previously well people with sudden onset disease. You have an upper airways involvement, and sometimes plus minus an acute bronchitis. Common cold is a self-limiting disease, average duration of 2 to 3 weeks, and it's very important. The most bothering symptom of the common cold is cough. Why is cough the most bothering? Because the cough lasts very long. It can last up to 8 weeks. If it's Bordetella pertussis, then it can last even longer. So chills and rhino probably last 2 days or 3 days. So you don't need to have an acute bronchitis with mucosal inflammation in the tracheobronchial tree to get cough, because cough will be elicited from cough receptors. They are very dense just in the upper airways, pharyngeal and laryngeal cough receptors. So, what are the possible diagnostic procedures? You can see there, as I told you already, I am a respiratory physician. Sadly, you don't need a lung function test, you don't need chest x-ray, you don't need laboratory tests, and then still you have an efficient economic diagnostic procedure if you take the history and the physical exam. There are some caveats, some exceptions, but you can see here the so-called red flag signs. If you have hemoptysis, severe chest pain, dyspnea, high fever, and so on, with acute symptoms, then you should introduce immediately some other investigations, diagnostic procedures. Yes. What are the treatment options in common cold? The most important question, I think, is whether watchful waiting in a self-limited disease justifiable. Watchful waiting means you do nothing. I think it is not practicable and not justifiable. What about placebo treatment? This is the placebo curve of a double-blind randomized controlled trial, and as you can see, after less than 2 weeks placebo treatment, you have a decrease in symptoms in the majority of the patient. So is it justifiable? I think no. I told you that common cold is really a trivial disease. But the symptom burden of common cold to the patient is not trivial. It's a very high symptom burden. And so if we have, and I will show you that we have effective treatments for this problem, then you should use this treatment. So what about antitussives? I like antitussives. Antitussives are the logical treatment of cough in common cold. However, in the last 20 years, if it was a progress in medicine, then probably the most important is the use of evidence-based medicine. And we learned that logical, it's not evidence-based. What are the facts? Prescription codeine, which is the gold standard for antitussive treatment and well-working in cough provocation tests, well-working in lung cancer and so on. It doesn't work in acute bronchitis. The effect of codeine is on placebo, exactly the same as placebo. It was investigated several times. A little bit better is dextromethorphan, which has not only a central but even a peripheral effect. I am not worried that you get mucoid impaction according to use of dextromethorphan because the effect size is very small. You all know probably the clobuterol story. Clobuterol was marketed under the brand name Silomat over 40 years and then withdrawn for the market a couple of years ago due to cardiac arrhythmias. The FDA warning, yes, I am an adult physician. I don't want to carry colds to Newcastle. You know it much better than me that cough and cold remedies the FDA wants to stop, especially in toddlers. And the combination antitussive, very popular in the US, were stopped just a few months ago. Sorry, Larry, but the FDA is really cracking down. We are going to have to let you go. This Rob Rogers was published in Chest, but you can show this is a real problem in the US, that this combination treatment, antihistamines with pseudoephedrine, a lot of preparations in the US, on the US market, and the marketing were stopped due to FDA regulations. Yeah, we have the antibiotics. You know as good as I do that antibiotics are the most frequent prescription drugs in common cold. The question is only whether they are appropriate. I think they are not. Here you have survey, a European Primary Care Network survey, Antibiotics for Common Cold. Here you can see 14 different primary care surgeries in different countries, and it was registered how often people got a prescription for antibiotics for common cold. As you can see, 85% in Slovakia, in Bratislava, and as you can see, as opposed 20% in Barcelona, Spain. And what do you guess about the resolution of the symptoms? Where was the resolution better and faster? It was exactly the same. You are not able to distinguish between the yellow and the broken yellow and the broken green line between Bratislava and Barcelona. Exactly the same resolution, with and without antibiotics. One would guess probably that people would benefit from antibiotics. Exactly the same situation. No difference even with purulent sputum in acute bronchitis, whether you get antibiotics or not. And 10 days ago, the Health Protection Agency of England performed a survey, published a survey. A quarter of people wrongly believe antibiotics work on most coughs and colds. This survey was not performed in Germany. In Germany, would be the result, 75% of people believe antibiotics work. So it is the problem that we face now, and more and more antibiotic resistance in the community. Do you need ever antibiotics in acute bronchitis? Yes, you need. If you get the acute bronchitis complicated by bacterial superinfection, about after 5, 6, 7 days or plus, you can decide whether the patient has a bacterial superinfection, and this is the time to prescribe antibiotics. You can give the patient a prescription at the first consultation and tell him, wait, if after 6 days, 7 days, you still have problems, you still have coughs, you still have sputum, you can start with antibiotics. The second problem is there are some cases, probably less than 10%, of primary bacterial etiology of common cold, and you see there are different bugs, not the same as you see here, and probably the situation is different, I learned, in children and in adults. At least in adults there is no benefit from antibiotics, even if you give an antibiotic effective on these drugs in adults. In children, again, it is different. So, what about mucolytics? Mucolytics are a very popular medication in Germany. I think it is the largest OTC, over-the-counter market in Germany for common cold. I guess this is a misconception, because mucolytics, if they work in this condition with severe structural changes in chronic bronchitis. And there is a place for some good, effective mucolytics in this condition, but it is definitely not the case in acute bronchitis. What about the next step, inhaled corticosteroids? Inhaled corticosteroids and inhaled long-acting inhaled short or long-acting beta-2 agonists are very effective against common cold cough in patients with bronchial hyperresponsiveness, infectious asthma, They are very happy with this medication. However, this medication was extended to all people. It's better than antibiotics because antibiotics are not better as a placebo. But this is a misconception again, and now we have 2 more papers published that anti-asthmatics will not work in non-asthmatic, non-bronchial hyperreactive patient. Bronchial hyperresponsiveness can be exaggerated by a common cold, by acute infection. And what remains is the phytotherapy. There are some in vitro papers with efficacy for bronchospasmolytic, mucolytic, antiphlogistic, antimicrobial, and antiviral effects of different phytotherapeutics. And the question was whether these in vitro benefits, these in vitro results, can be translated in clinical benefit. And there are now several studies. 2 studies were performed by Bionorica, and I show you now the Thymellvy Syrup versus placebo in acute bronchitis. This was the first double-blind randomized study according to statistical needs today, contemporary statistical needs, and this is the patient disposition. Some 350 patients were included, 308 were evaluated per protocol, and here you can see the design of the study, the Thymellvy with 180, the placebo arm with 180 patients, 3 times a day syrup for 11 days. And then you have the endpoints, the primary endpoints, the frequency of cough bouts, percent patient without cough on day 9, and some more composite score, the bronchitis severity score. And here you can see the number of cough bouts on day 9 with the syrup versus placebo, and the results. You see the natural history under placebo, and here you can see the effect. This difference is highly significant, and it is clinically relevant. This slide you did already see this until 50% reduction in cough under placebo, and here you can see that at day 6 you have 2 days difference relieving symptoms if you are giving not placebo but you give the Thymellvy syrup. And I told you already, common cold is a trivial disease, but the symptom burden is not trivial. And if we have an effective drug and you get 2 days improvement, 2 days faster, then you should use such a treatment. And the composite score, the most important symptoms of common cold as cough, sputum, rales, chest pain by coughing, or dyspnea, 0 to 4, you have 20 points maximum score, and this is the situation in this study. Patient had some 8 points on the bronchitis severity scale, and a few days later, 7 days later, you have already a statistically significant difference. There is clearly placebo effect because this is a self-limiting disease, but you can help the patient if you give an effective drug, and at the end of the study there is even more difference between the placebo arm and the verum arm. What about side effects? Side effects are on placebo level. There is no difference. You don't have to have concern about side effects if you give such a treatment. This is for you because this is a post-marketing survey for children, different age groups, 2 to 5, 6 to 11, 12 to 17. And you see the same bronchitis severity score at the inclusion and the same decrease with the drug that you had seen on the randomized controlled, placebo-controlled conditions. This is the second study. Thyme primrose tablets are working as well. The study design, the patient population was exactly the same. I don't show you this slide. I show you only one slide that you can compare. This is the percent change in cough bouts, the primary endpoint, and you can see the Thymellvy, the Thyme primrose tablets, the syrup. You have the same decrease in cough bouts. You have the same difference between placebo and verum. So, in conclusion, a cough improves faster if you treat it with the drug. Other symptoms improve faster, see bronchitis severity score. Twice the number of patients on drugs stop to cough after 11 days. And the safety is no concern, and importantly, if you give such a treatment, you will not foster antibiotic resistance, and you will give the patients an effective treatment. And the placebo-controlled randomized trials give an evidence that in the German cough guidelines, phytotherapeutics were included, especially the two I show you were included with recommendation A for the treatment of acute cough. Thank you very much for your interest, and we can discuss.